While you're getting your seats, I'm going to get started so we can take full advantage of the time. I want to thank our sponsors. We have lots of sponsors for this event, and no wonder there's a lot of people here who they can influence. Speakers, pay attention to who your sponsors are, please. PwC with Wayne Samuels, who's here. Hurock, I see Peter Flattery was here, and George Furtado. National Research Corporation with Jeff McDonald. Orion Health with Gary Falker and Matthew Mainling. Cerner is here with Jim Shave and Graham Somerville. One other note, please. Please tweet. I don't remember ever asking that, but please tweet. Please tweet generously. Take pictures and tweet your pictures. These guys are all going to go right back to their office, ask their secretaries to say, show me the tweets. No? I think that's the first time we've encouraged people to use their Twitter accounts. So thank you very much. The next breakfast, so you might think about coming to it, is Breakfast with the Chiefs on March 4th with Michael Scheer, Catherine Zahn, and Staney Brown. So that will probably have a lot to do with cancer care, although I'm not sure what the subject is. They can do whatever they want. So, and a very big thanks to Rotman, who the university is always very generous in giving us space, and Brian Golden and his whole team. We're glad to be here, and we're glad to fill every single seat. I don't need to introduce our speakers, but I will introduce our lead speaker, Barry.
It's actually Brian who's going to start. That's fine.
He's the lead speaker, but Brian's going to introduce him. Apparently, I'm not good enough.
You're good enough. So welcome, everyone. Anton was very clear with me that my job is really to play traffic cop today, and if the questions are getting a little too soft and easy in the middle of this, I've got a zinger or two. But I think the introductory comments from each of our four speakers will stimulate a lot of interesting conversation in the group. So we've first got Barry McLellan from Sunnybrook Hospital, CEO and president, and you all have had their bios, and they're all quite long, so I'll be brief. Kevin Smith from St. Joe's System, Jack Kitts from the Ottawa Hospital, and Leslee Thompson from Kingston General. So all friends, all my friends, all friends of each other, and all doing really interesting work around innovation and focusing on the patient. So what we're going to do is we're going to hear from each of the four speakers, and then I'll open it up to Q&A. I'll ask that you, and I'll probably have to remind you when you get the mic, let us know who you are, your name and your organization, but no more, please. And genuinely ask a question, as opposed to make a statement and then have them try to figure out what the question should have been. Okay. And then that's it, and we'll wrap up right at 9 o'clock. So let me turn it over to Barry first. We've done it in alphabetical order.
I'm going to go up here. Thanks very much, Brian. Good morning, everyone. I appreciate having the opportunity to be here this morning, along with my esteemed colleagues, to address a really important topic that I know all of us are passionate about, and that's advancing the patient experience, and then the theme today around innovation. So this morning, I'm going to be presenting on a Sunnybrook innovation called MyChart. And before describing exactly what it is, how we introduced it, including some of the important change management pieces, and what we've learned from the experience, I'm going to start with some general comments and some context. So the first is that as we are all focusing more and more on enhancing quality of care, we're learning with time the importance of providing care with patients, not for patients, and that's going to be a common theme this morning. Secondly, better informed and more engaged patients make for better health and better health care. Thirdly, what we've traditionally considered, and this is relevant to my specific topic, to be our medical records, in reality are the patient's medical records. And finally, by way of context, over 80% of Canadians have told us that online access to their health information is a key component of what they want to see as part of their healthcare journey. So what exactly is MyChart? It's a personal online health management and continuity of care record. It's designed with patients for patients. Through MyChart, the patient is the owner of their own health information. They're in control of it 24/7, and they have the ability to share that information with family and various healthcare providers. So we first started down the personal health record path in 2006. So it's taken us just over 8 years to get to where we are now. Our underlying goal was to create a record where patients could access and manage their health information based on both personal information that they would enter and clinical information. So the key considerations at the get-go that are relevant with respect to much of the change management that I'm going to cover, we wanted to ensure that this record was mobile and portable, that we dealt with privacy and security, one of the most important issues from the patient perspective, and it was relatively low cost in terms of design and implementation. So the concept was built around a direct link connecting our hospital information system, OASIS, with the real-time feed of clinical information. So MyChart, in response to those key considerations, allows patients to access and share their information from anywhere in the world where there's an internet connection. Application development was mandated to meet the security standards that are used for online banking. And MyChart was built using a lot of our own in-house IT and privacy expertise, which minimized significantly the upfront costs. So the MyChart record includes personal and family health details that are populated by the patient. This includes a personal address book and diary, other information they may wish to include. It includes online appointment requests. Importantly, and this is what I'm going to be focusing on in a few minutes, test results from our health information system. That includes lab, EKG, echo, diagnostic imaging results, and allows for e-messaging with participating physicians. And then finally, to assist with ongoing patient education, there's links to health and healthcare information. Now, one of the topics we were specifically asked to address this morning was change management, and there was some interesting change management associated with MyChart. As you can imagine, we targeted the two groups most relevant, turns out to be in ranking order for this, the physicians and the patients. And much of the change management needed to deal with the physicians themselves. So one clear and consistent message from the get-go, and the physicians did concur with this, is that we were providing patients with access to information that rightfully belonged to them. So the discussion was around how we were going to do this. It wasn't around whether we were going to go this route. The physician strategy involved introducing MyChart through a pilot phase. We took a very stable practice. We used our osteoporosis clinic. We targeted clinicians who were thought leaders and champions, and we introduced it in a very controlled fashion. Now, there were three concerns that I want to highlight from the physician perspective. One, they wanted to ensure that the information in this record would be accurate. The effect that the patient portal would have on the physician-patient relationship, and that's the most important that I'm going to come back to. And then finally, some practice management concerns, which is really code for they didn't want to feel that this was downloading something onto their office-based practice and increasing their administrative load. The accuracy piece was easy to address because the clinical information that's in the record can't be edited by patients. That goes into the section where it's a direct feed from our record, and it's basically a reflection of the content that's in our OASIS health information system. Patients can only edit and change information that's in the personal section of their record, including their personal diary. And if they want to, documents they may wish to download from another healthcare organization. So as I mentioned, the physician-patient piece was the most challenging to address. And the concern was that potentially life-changing results could be made available to a patient before there be any kind of communication with a clinician. And I vividly recall going to a medical staff meeting during the rollout phase, and there was some real passionate concerns and objections about how this would actually work. And you know, you can understand where some of those concerns might come from. One of the advantages we had is we had patient information from the initial work through the osteoporosis clinic, and patients said, we're not worried about that. We actually want the information as soon as we can possibly get it. So we worked with the physicians. We found some common ground on this. We built in a delay initially with respect to when the results would appear in the record. And with time, that's translated to the only delay that we have now is around the pathology records. There's a 2-week delay built in. Everything else goes out immediately when it's available. The patients love it, and the physicians have become completely comfortable with it. With respect to the practice management or workload concerns, those were easily addressed in that we talked about the advantages that this would bring to office-based practice, and the administrative staff, in fact, became some of our earliest champions, talking about it actually made it easier because patients weren't calling them to access information they could get in other ways. The patient-centered piece was mostly around awareness and promotion of use, and as I'm going to cover in a few minutes, the numbers, it has grown significantly, so patients themselves became the best way to communicate this to other patients, and their major concern was that of security and privacy. I've indicated the level of security we have in place, and patients quickly became comfortable with that. So all to say that the most significant change management piece, as with many of our initiatives, was actually around the clinical staff, not the patients. Patients loved MyChart from the start, and the physicians grew more and more comfortable with time. Now, we've introduced some changes that I quickly want to highlight, and then I'll talk briefly about our experience. We now have a version 2 of MyChart with a more open architecture. That means it's compatible with other health information systems. We have Cerner-based organizations using it now, very, very smooth. And the technical types in our organization say that MyChart can, in fact, be used with any of the health information systems now. And we made it more useful for mobile devices and tablets, and that was one of the other significant changes. So very briefly, some of our experience. We've now got over 60,000 users. We've got 4,000 family members who are working with the users. Most commonly, it's the seniors who want to have access by their family members, and that makes good sense. Just by way of numbers, we've got about 25,000 lab tests and about 6,000 pathology views every month, so it's being used a lot. The remote access is a very big deal, particularly for those with chronic disease who travel. The snowbirds absolutely love this. They go down for an unanticipated episode of care. No matter where they are, they can get access to their records and make them available to those who might be providing care. And we've partnered with a number of organizations. I'm just going to name a few. Baycrest is using this. Mount Sinai is now at a pilot phase. We've got CCAC is using this. And we now have memoranda of understanding being developed with Mackenzie Health, Ottawa Heart, Osler, and others. So it's gradually, with time, expanding. So most importantly, this is about patient experience. The patients love it, and they tell us that it improves their experience. We do lots of surveys. Patients tell us that they're more active in their care, that they tell us it improves, from their perspective, quality and patient safety. They have direct access to care team instructions, discharge notes, their key information, medications, allergies. They're better able to track appointments, and they're far more engaged around screening and reminders for upcoming health appointments. Our physicians, and this is where I want to close, they now are some of the best champions that we have of this. We have a series of videos that include a number of those physicians who raised concerns at that medical staff meeting that I described to you. They passionately talk about how MyChart makes it easier for them because their patients are better informed and more active and engaged participants in their care. So in concluding, some of the most important innovations are, in retrospect, comparatively simple in concept and execution. MyChart's an example of listening to patients, responding to what they tell us is important, building on existing technology and expertise. This was not that complicated. To do at the end of the day what really is important, and that's providing care better in partnership with patients. So appreciate your attention. I look forward to the other presentations and to the discussion.
Thanks, Barry, and congratulations on a great job. I thought we were here to announce the merger of Sunnybrook, the Ottawa Hospital, Kingston General, and St. Joe's, but here we go. I'm here to talk about, I'm from St. Joe's Health System and the Niagara Health System, and I'm here to talk about integrated care initiatives. We have had the good fortune of being Ontario's first integrated system across the continuum from primary care through to palliative care, including academic teaching sites. And the challenge, I think, that came before us, which is obvious to all of us previously, was in a board retreat when we brought our system together, board members talking about what's wrong with the system, continually came back to the points of transition. Their unbelievable frustration at every point of transition in the healthcare system, and often the unintentional undermining of one another. The last provider I talked to told me this, and now you're telling me that. The next provider I talked to told me something different than the last provider I talked to, leaving patients often feeling adrift and with information that was less than adequate. The frustrated board then said, management, do something about this. You have the continuum now under a common management and governance structure. Get on with it and do something. So working with our ministry colleagues, and I have to recognize our colleagues at the ministry, our colleagues at the Hamilton Niagara Haldeman Brant LHIN and the Waterloo Wellington LHIN and the CCACs of those same two regions. And a special shout out to the person at St. Joe's who led this, Dr. Carolyn Goss. We then sort of sat down and said, well, what with the ministry, what kind of areas would you like to see some integrated work done? We landed on a list that included lung cancer, where we were the regional referral center, so we had a LHIN or more to look after. At the time, hips and knees and their costing was a very important ingredient, and QBPs were alive and well and being developed, so we do lots of them, so we agreed they should be two. Then we came back to chronic disease, which we all talk about but is often difficult, and landed on COPD and CHF, one because we were a respiratory center and the other because of the numbers of admissions. And then lastly, at our Kitchener site, which is a community-based tertiary cardiac center, also included coronary artery bypass graft. And really what we ended up doing was saying, let's take our home care division and our hospital division and put them in the same room. And we forced some pretty difficult conversation. It's all very polite to begin with. And after Carolyn, in a very skilled way, pushed quite a bit further and said, well, tell us what you really think about one another. And this is a gross summary. The hospital people said, you people in the community are very, very nice, and we know you're very good at hand-holding and bathing, but we have really sick patients. You couldn't possibly look after these people. They're much too sick for you. And the home care people kind of smiled and nodded, and then it was their turn, and they said, you people in hospitals are a comedy of riches. You have everything. You allege you're a 24/7 service. Whenever we call you for anything, remember this is in the same family, whenever we call you for anything, your response is one answer: go to the emergency room. That is not the help that we need. That sort of set the tone of an interesting day. And we then had a further discussion that said, well, what would it take to overcome some of those challenges? And began by saying, let's look at the clinical domains that I just mentioned. And the group then mapped out literally step by step that process, truly from primary care to palliative care where necessary. And the post-it notes around a room this size in terms of how many steps and processes were there. And then they began the process of elimination. They also focused very much on how would one do this and who would do the work and how would you buy engagement. And it really came down to a single team, including the home care worker and the surgeon, being on the same team and knowing one another. And you've all been in the position where it's a Friday afternoon and someone says, Dr. Golden, can this patient go home? And the answer is, well, what can they expect at home on the weekend? Well, you know what, we faxed it to the CCAC, and with all due respect, we're having some labor challenges at the moment. Well, tell me who's going to see the patient. Well, they have expertise in caring for lung cancer patients. They might, but they might not. Who can I talk to, and how would that happen over the weekend? Well, you could try to call someone, and we kind of went through over and over. The confidence at the end of that discussion was, I think the patient will stay in over the weekend. The New World Order is, if I'm the PSW, God forbid, and if Brian's the thoracic surgeon, God forbid, we really now have a relationship where Brian and I know each other, and we're having a conversation, and someone says, Kevin's on the weekend, and by the way, Brian's on call, and we have a very simple technology called an iPad that you two are going to connect on. And you can examine the patient's wound, and you can look at anything you want to do, and you can talk to the patient and the family. And when we started this, there was no billing code for that. The good news is, out of some of previous negotiations, there is some opportunity to bill for those issues now for physicians. But I have to say to you, over the 2 years where that wasn't the case, not on a single occasion did we hear physicians complain about loss of income or doing work for no income. And you recall I mentioned orthopedics in this. Some of you might be aware that sometimes orthopods notice money. And I was waiting for this orthopedic call, and I didn't get it. And I kept waiting and waiting, and I finally called the chief surgery and said, who's an orthopod, how come I'm not getting this call? And the answer was, it makes our quality of life unbelievably better. Our clinics run better. We don't have to try to fit patients in at the last minute. The nurses aren't mad at us. The patients aren't frustrated. And actually, I can do another couple consults a day. So all is well. We embarked also with one major rule. This cannot be a major IT install. For the vendors in the room, I apologize, but we knew we'd be retired or dead before we pulled that off. And really simply said, what are the very simplistic technologies that we already have? And to Barry's point, how will we use them and leverage them? And a very simple, inexpensive home care system and a very simple, inexpensive iPad works remarkably well and allows clinicians to have ready access all the time wherever they want it, be that in hospital, in the community, or in the primary care physician's office. So that was incredibly important. The other incredibly important thing that I think this program did was insist on third-party independent evaluation. And we contracted from the outset with the program for the assessment of technologies in healthcare, generously funded by the Ministry of Health. I think that's probably something we don't do enough in these initiatives. We self-evaluate, and then there are questions about our bias, which are obvious. And I think we have to we really learned a great deal from this. The challenge, of course, is making the intellectual and the scholarly valid and reliable to the practical. But it wasn't a problem, and I would say that it was an incredibly important part of what happened. I think the other thing that one of the other reasons we embarked on this was a senior management team discussion and a medical staff advisory committee discussion, and the concern of resilience. You're all seeing on the front line. We're feeling pretty beleaguered, and most of our frontline staff think that what's coming is the train, not in a great light. And we really began in this model to talk about, can you build a more resilient workforce? Can you give people more autonomy over work? And eradicated completely by both size and unit function, you could never say in this program that was another rule, we have to do this. I don't know why, but we've always done it this way. Eradication of that concept. If you don't know why you're doing it, your job is to bring that back to the care team and either change it or figure out why you're doing it or understand it differently. And again, when the people doing the work had that conversation, we stopped doing a lot of things that we really didn't need to do and collecting a lot of paperwork that nobody used anyway. The results of which, I won't bore you, I don't have time today, but all measures, by every measure, from satisfaction to efficiency, all extremely positive. The challenge is everyone wants, after you were successful, at first, of course, everyone's afraid of it, and then once you do it, every other unit wants it, and you've got to figure out a way to move there. The challenge, I think, going forward is probably how do you grow these kind of initiatives and still keep that local, small focus on teams that can make decisions and can change how they practice in order to make that flow happen more ambitiously. I'll just close by a quick story of what I think are increasingly the backbone of our system, our PSW workers. When I started off on this, I went to a session, a large group session, and I blathered on, as I am today, about efficiency and quality and sustainability. And a very bright PSW said, "I don't know what that means." And you probably don't know what that means either. She was probably right about that. We engaged in a little banter, and she said, "You want me to do this better, cheaper, and faster?" And I said, you're right. So for all of us now, the PSW has renamed the program. We call it Integrated Care Initiatives with scholarly audiences like you and in exalted buildings like these. But the real people doing the work call it the Better, Cheaper, Faster product. A few months later, I saw the PSW in an elevator, and I said, "Hello, do you remember me?" And I said, "I do." And she said, "I wish you didn't." And I said, "I do. And I want you to tell me how it's going." And I will never forget this experience. She said to me, "I've never worked harder, and I've never loved my work more. I used to be the lady who gave a patient a bath, and now I'm part of a team that cures cancer." And that speaks fundamentally to people feeling engaged in their work and engaged in contributing to something larger than the individual care experience, where often they felt disjointed, unconnected, and without satisfaction of outcome. The other good news I finish on is the ministry is now about to release a request for expressions of interest. I'm looking over at my ministry colleagues to make sure I got the language right. And we take that as a great compliment to the work that's been done and the work that will be done. Minister Matthews at the time said to me, "You know, it's very hard for a minister to fight against a project where the PSWs, the nurses, the doctors, the administrators, the patients, the LIN, and the ministry are all happy." So thank you.
Well, good morning, everyone. I feel a little sheepish after those two major innovative patient experience initiatives, because I think you may wonder if I'm at the wrong talk, because the innovation and change management that I'm going to refer to is really more about going back to the basics and bringing care back to the bedside. So in the fall of 2007, I received a letter from the husband of an elderly lady who fractured her hip and wrist on the Friday of a long weekend and spent the next 5 days in the Ottawa hospital. Today at the hospital, it's referred to as the letter because it provided that really burning platform for a journey that would lead to a culture where the patient experience is everything and a destination where every patient has the best experience every time. We began with a new vision: to provide each patient with the world-class care, exceptional service, and compassion that we would want for a loved one. We changed our strategy, and we set a goal that would see us in the top 10% of academic medical centers in North America for patient experience and quality of care. I know this is a big, hairy, audacious goal, but after discussing it, we felt we owed it to our patients to at least try. Our strategy had 3 components. 1, invest in service excellence training for all staff. And one of the programs, coming back to Kevin's, is everybody feels that they treat patients, that they care for patients, right from the electricians to the housekeepers. The second was invest in information systems so we can actually measure and then manage our performance. And 3, create an engaged workforce that included all staff, support and clinical, and particularly physicians. We also engaged patients in many different ways to ensure that their voices were heard throughout the hospital. The letters are still a valuable part of our patient experience. And what they told us consistently, and consistent with other patients in other health systems, is what they really want is better communication with their nurses, better availability of their doctors who listen and include them in the care plan, better pain management, a quieter environment, particularly at night, and a safe discharge home. In response, we implemented the following. Every member of the staff is required to acknowledge the patient by name, introduce themselves, state their role, and explain why they are there. Nurses round on patients each hour. The patient care board is current and complete, and the nursing shift reports are done at the bedside and include the patient. And all patients receive a post-discharge phone call within 48 hours. And the managers on the unit are expected to round on all their patients daily. To measure progress, the board evaluates the CEO and the chief of staff as a dyad, using a single scorecard, same metrics, same targets and outcomes. In fact, the patient experience metrics account for 50% of the weight of our evaluation. And to ensure alignment, vice presidents and department heads, directors and division heads, and managers and frontline physicians are also evaluated as dyads with the same metrics, same targets. And every 4 months, the entire management team at the hospital, about 400 strong, and the medical leadership, about 80 physicians, meet off-site to participate in the Leadership Development Institute, or LDI. The LDI provides a forum for a State of the Union address by the Chief Executive Officer and the Chief of Staff on progress on how we're achieving our annual targets on patient experience and quality. It also allows us to be transparent and publish our results and benchmark our performance at the unit and individual physician level. So the high-performing units, and we rank them, will get up and talk about their experiences and lessons learned to help the lower-performing units. And I can say today our patient experience is better, much better. Our nursing communication is better, and we manage pain better. Patient falls and pressure ulcers have decreased, and call bell frequency is greatly reduced. The discharge is definitely smoother and safer, and overall patient feedback is much more positive. But it hasn't been easy. Despite having very clear patient directions on what they need, and a prescribed evidence-based behaviors that appear to be easily replicated, the pushback still comes. And the pushback comes from all levels, managers, physicians, and frontline staff. Some say top 10% isn't even a reality. Perhaps, but shouldn't we try? Others say the system is the problem and limits us in improving the patient experience. I found that patients are well aware of the many challenges in the system, and it's amazing how understanding they are of the system issues. But what they don't understand is when hospital staff isn't kind and doesn't communicate with them. And still others say, we're too busy to provide the care our patients expect. It's remarkable how much a little empathy and compassion means to the patient experience. It's really remarkable, and how little time it really takes. Staff actually feels much better when their patient experience is better. So I will end with what I believe are the 3 most important factors for success. First, patient and family engagement. You got to know what they want and what they need. Equally important is board engagement. It's the board that drives it, keeps it moving. There's a lot of off-ramps that you'd like to take over the 5-year period. And so to have a board that's engaged and pushing it forward is really important. And third, all staff engagement, not just the nursing staff or the physicians, but all staff engagement. And in fact, I would say if any one of these does not exist, your chances of success are very low. Today, we are a better hospital with better patient experience and better quality of care. But remember, our goal is the best patient experience for each patient every time. Our journey is continuing. I look forward to your questions and discussion.
6 years ago, Kingston General Hospital was a very different organization than it is today. We were an organization in crisis. If we were a patient, we would have been diagnosed with multi-system failure. Graham Scott had been in the organization and essentially had the role for the whole year before I arrived in February 2009 of stabilizing the patient and giving it a kickstart and a focus in terms of facing the many challenges that it had before it. When I arrived, the biggest challenge, in fact, was not all the operational, clinical, and tactical challenges that needed to be overcome. It was finding a way to ignite the heart and the soul of the organization and people together to achieve results that at the time we, to a person, thought were probably impossible but necessary. Today, I can proudly say that when we look back, all 7,000 of us who work, volunteer, learn, and lead in the organization, we're really proud of having not only moved mountains, literally mountains, with the clinical, operational, financial, and many other changes that were put in place to build our organization toward a high-performing organization. What we're most proud of, though, is the fact that we've moved mindsets, our mindsets. We work and we are different today in very real ways. As a start, what we did was go out and engage with patients and families in ways that many organizations do. We listened, and I personally listened and was involved in 3,000 interactions of learning about how we were actually going to move forward. Some of the messages we heard were very, very difficult to hear. And I will never forget a patient standing up in a forum like this and said, "Leslee, I am afraid to go to your hospital." And I thought, I can handle you don't like the food, we're not polite enough, but to be afraid is a very poignant feature of an organizational culture. Also, my staff were afraid to speak up about changes that they wanted to see in the organization. So we mobilized around a common mission, a mission that was actually fairly simple. We believe that we are a community of people dedicated to transforming the patient and family experience. That's our purpose. That is our sole purpose, and committed that everything in the organization that we did, how we behaved, and how we made decisions would revolve around that. I've been part of many experiences like you where we say things like that, and then it all peters out in the real life translation and execution. So we made a bold declaration. One of the biggest and most profound decisions that I've ever made and been part of in my career. We said that if we're true to transforming the patient and family experience, we must be true to involving and engaging them in everything that we do. We can't do this alone. So we put down the gauntlet and said any decision in our organization where there is a material impact on the experience of patients, a patient will be at the table. Now that was 6 years ago. You look at every decision and all the decisions you make in your organization, public sector, private sector, and think about the impact on the experience of your customers. There's a lot of decisions you make every day that make an impact like that. So we set out to make it real. We had no idea how we were going to do this, but we had a resolve that we believed that that would be our guiding force. So we started. And how did we do this? We focused specifically on the bedside, implementing many changes within a model of patient and family-centered care with many of the features that Jack described in his organization, and held ourselves accountable for not just doing them, but monitoring, evaluating, and making sure that those were happening. And we started making it real at the bedside with decisions about the clinical care plan for the patient needed to involve and engage the patients. And we put lots of processes and initiatives in place around that were co-designed with patients. Secondly, we worked at the units and knew that we had to constantly exchange information and make sure that we were working together across every decision. And so patient feedback forums and a whole variety of initiatives, patients invited into not only the Patient and Family Advisory Council, but invited into the decision-making forums and the discussion forums that were shaping decisions at every turn, at councils, in committees, and any decision. The test was, is this going to make a material impact on the experience of patients? We needed to support this at the boardroom as well. And there are times when decisions needed that overall support from the organization. When you go to eliminate visiting hours, when our patients and families said, what is it with those? And we stood behind the advice that we got from the council and our organization and said, absolutely, and we moved forward quickly and have made that real. Building trust when you make changes like this is absolutely critical. And trust is built on your behaviors day in, day out, every moment. Every leader in the organization is part of building and shaping that culture and environment of trust and transparency. As we move forward, it wasn't a smooth or linear path. Like others going through change, we had a number of times where we recalibrated our approach, especially focused on this decision-making component. First, opening ourselves up to conversations with the community and in our communities about these, about the work that we were doing became absolutely paramount. It was scary to go out there and talk about things in a new and open way, but we brought people in and had those difficult conversations in public forums. We threw open every part of our information transparency in our organization of how we made decisions to patients, to families, to the community. We moved forward in the face of challenging experiences like patient dying of hospital-acquired infection, that we actually realized that in fact we said we were here to keep people safe, but we actually weren't upholding that commitment, and we invigorated our resolve to address that with focus on a few vital behaviors, including hand washing. 4 years ago, our hand washing was 34%. Today, and the past 3 years, we have been at 95% almost consistently because of that translation of the value and belief into everything that we're doing and into concrete behaviors. When you go down this path, everyone says that they're for the patient, and in fact, one of the things that we learned is that it's easy to be superficial about this, and you've got to go very, very deep and look at and hold yourself accountable for shifting and shaping the decisions in a much different way. When we made a change in our food services, we involved patients in the RFP process. They were at the table, they were tasting the food, and all of the various changes. We had 5 days of protests outside of our organization, but we could stand tall and stand firm with the knowledge that we actually were patient-centered, we were involving patients and families in the decisions every step of the way, and we could stand the test of pushback. Leadership has been a key part of the shift in the organizational culture when it comes to decision making, and I want to share briefly with you the features of the leadership model, patient-centered leadership, that we practice at KGH to help make this happen on a daily basis. There's 4 key elements to patient-centered leadership in our practice. First is always see beyond the numbers. Peopleize the numbers is the practice of what we talk about at KGH. We learned from a patient who was sitting at Infection Control Committee, one of our MAC committees, when we were talking about the statistics of 0.08% of improvement, and she said, how many people came to KGH this month without an infection? and left with one because we gave them one. That's hospital-acquired infection. That's peopleizing the numbers, and the challenge to everybody in the organization is every number, every report must be peopleized. Second, have you included a patient and family in the decision-making process? From the formative stages in the decisions as they move through the organization. Our patient and family advisors have as much power as our medical advisory committee. So we need to demonstrate and translate that understanding at every step of the way. The third is the question that we ask ourselves, and the one that I use on rounds all the time, is asking ourselves, what did you learn from a patient today? That is a simple question that every leader in our organization is expected to be able to answer, to be able to reflect on, and share the story with others. And if you can't answer that question, what did I learn from a patient today? Our assertion is you're not spending time in the right place. And so the combination of these practices from a leadership level and really bringing to life the decisions about making decisions in a different way have fundamentally shifted the culture in the organization that we are living differently. This is not a unique experience at KGH. What I think is unique, when we've now had 154 organizations come to visit us to learn about what we're doing, because I think the difference in the engagement strategies that others are doing is the depth and extent of involvement of patients and families in the fabric of the organization. But this is happening on a global level where people are really trying to grasp how do we do this at the patient care bedside, at the organization level, and at the system level. And I always say you have to start and be true to this on the ground every step with every single patient interaction. Otherwise, all will be for naught. But if you think that this is something that will pass, I would challenge you to think again. Patients and families have a major voice right now that is increasing in volume, intensity, and impact. Social media, it's incredible what people talk about you out there and the experiences they have, and these conversations and the activism that is starting to happen, I think is one of the most exciting things that's happened in healthcare. Truly engaging and truly partnering with patients changes you as a leader and changes the organization. I believe that we are actually now in healthcare at a point where I call our Copernicus moment. Copernicus is the mathematician and the astrologer who 500 years ago, people thought he was mad, but he convinced people that no, the solar system didn't revolve around the Earth. It revolved around the sun. I think patients and families are the sun in the system that we are finally coming to terms to say this is where the patient and family belongs, at the center, and we are but one organization that's tried to make that true and real in every decision that we make at Kingston General Hospital. Thank you very much.
You can have my seat. And so we want to make sure we have time for Q&A, and again, as a reminder, I'll ask you to stand up, tell us who you are, where you're coming from, and I'll also encourage not every panel member to answer every question, but only if you've got something unique and maybe in conflict with your colleague to say. As we're getting the mics around, I want to start off with a question that's started with this notion of the Copernicus moment. I want to commend all of the organizations for the innovations around patient and taking advantage of technology and moving organizations together. But I also want to make an observation that nothing you described today couldn't have been done in Ontario or Canada 15 or 20 or 25 years ago, and in many jurisdictions they have been. So I'm curious about what do you see as either the change in the external world, either government or the voice of patient, or I don't think it's technology, or incentives and funding that has led us to these critical innovations, but innovations, again, that could have been stimulated perhaps years ago?
So I've been voted to begin the response, Brian. You know what, I think you're right. Many of them could have been done 15 or 20 years ago. I would say culturally, 15 or 20 years ago, we weren't a data-driven system. We're not as data-driven as we'd like to be yet. But I think the Copernicus moment might be the embarrassment of variation, which I think would be one initiative. The second, I think, is we have seen similar initiatives bear fruit in other parts of the world, and you know, emulation being the highest form of flattery. I think that's allowed us to move forward. I also think, and I see Chris Carson is here, we had a pretty brave minister in our case who said, I'm going to break some rules and I'm going to let you break some rules, and I think this makes sense. So I do think that there was a different agenda, and I think that there was a frustration in the system. Barry mentioned this, well, all of us, Barry, Jack, and Leslee mentioned, I think we had boards who 15 or 20 years ago came and nodded and listened and had lunch and smiled, and we told them how good we were. And I think we have boards now who are, I'm from Missouri, show me, and I'm not having the kind of experience I expect. And I work in a sector where the customer experience has been radically transformed. I no longer find it acceptable that healthcare is absent from that evolution.
Thank you. Okay, we'll look to folks from the audience.
Chris Halling from the Toronto Region Board of Trade. Just a quick specific question for Barry on the links to pharmacies and drugs. Are there plans in my chart to have kind of accurate drug information captured in that system as well?
Thanks, Chris. So the answer is not yet, but in order for a patient record for their own purpose to be as complete as possible, we need to have more inputs than we have right now. It's really, quite frankly, a convenience that we have done this through institutions and our own records, but quite frankly, their record should include all of their episodes of care and everything they deal with in care, from their family doctor to their medication information that comes from pharmacies and others. So we believe that with improved connectivity, we're going to move in that direction. Do we have plans right now to take it there? No, but we are having discussions with multiple partners right now about where we can go next.
Good morning. My name is Peter Rotman. In light of my brief chat this morning with Professor DeCruz and the break-off in the negotiations with the OMA, I'd love to know your opinion about doctors' salaries, but I'll leave that. Leslee, I think you're being a bit modest in terms of the Copernicus moment. I think that with all of your involvement with the Ontario Health Innovation Council, I think we have a broader opportunity across the province in terms of what we have here in 2015, and I'd like to know your opinion about innovation across the province. What you've done in your hospitals here is fantastic, and I'd like to know what you see for 2015 across the province in terms of innovation.
Maybe I'll start with that. Related, I was a member of the Ontario Health Innovation Council that you referenced, and what we talked a lot about at the, that Ontario has a lot of the winning conditions that are here already to help advance innovation, and yet we have a number of roadblocks that we've put in place ourselves that can be removed so that we can accelerate innovation, and more importantly, we can learn how to scale and spread. in a very systematic and disciplined way. And the recommendations from the Ontario Health Innovation Council speak to the very specific strategies that we are recommending to the three ministers of how that should look and unfold. And I think that it's the discipline, the focus, and the spread and scale of initiatives to get the ideas into practice quickly by working with industry, patients, families, organizations, regulatory bodies in a very different way than we are today. And we are really looking forward to seeing those recommendations come forward. But I think, as you see and hear from all of us, innovation won't happen if these become one-offs. The true innovation to achieve the underlying principle that we all are working toward, which is improving the experience of care, improving the health of populations, and reducing cost by involving and engaging patients. We need to learn from each other, implement, and then keep iterating and advancing along the way together.
Yeah, just to follow up, innovation is one of the things that has become a buzzword in healthcare, that if we could only spread innovation, the system would be much more sustainable and better quality. At CAHO, the Council of Academic Hospitals Ontario, a number of years ago, we put together a project. In the interest of time, I won't talk about it in detail, but basically, if we agreed as a council that some hospital was doing something innovative and it would be useful to the system for the rest of us to take it on, we agreed to the spread of innovation. And I think in a nutshell, it's not so simple as they're doing it, why don't you do it? I think the science of spread of innovation is a lot more complex than any of us know. But I think the sooner we learn how to crack that barrier of not expecting innovation to spread by osmosis or diffusion, but actually get into the science, I think we'll all be better off. And by the way, there's any four of you could be sitting up here talking about innovations in your hospitals, and that's all great, but I think the real key is how do we spread it?
Morning, Peter Vandervelden. I run a healthcare venture capital fund called Lemera Capital. Barry, my question's really for you. First of all, congratulations on rolling out a patient-centered solution like MyChart. But the question is, when you started this project 9 years ago, how did you go through the process of evaluating make versus buy on a continuous basis? We've obviously seen dozens of companies doing MyChart type solutions. In fact, I think there's many solutions in the US that actually also have the MyChart name. So how do you do that? And then how do you transition potentially to becoming a software company as you roll this out to other hospitals and start to be the provider of the service? How do you meet that challenge?
Right, so let me try and cover those off fairly briefly, and then maybe I can follow up with you after in more detail. So why did we build this? When we looked at what was available and those considerations we had, specifically that mobility, the ability to access through the internet, be able to link to our record, we actually couldn't find anything that met all the considerations, so we built it. And most of us sort of go back and forth like a pendulum between building and buying and building and buying. For this one, do you know what? I think it was the right thing to do. And there are other products out there, most of them US-based. There's none that actually brings everything that we've got, that from what we can tell. And a lot of those are specific to the organization, and quite frankly, that there's a business reason why that organization has gone out and done it for their patients. And this wasn't about that. This was truly just, what patients would best benefit from and what they wanted. So for us, build was the right way to go. So what are we doing with this as far as others who might want to use it? Do you know what? Anyone, and I listed some of the partners we're working with right now. We sign an MOU. There's like an upfront investment on our part to be able to make it so that it can be used in another organization. We're not, I got to tell you, making money off this right now. I think that's where you were getting to as far as other organizations. Many of you are having discussions with us right now. I think our maintenance and support for what we do is about $10K a year. So we should have talked to you about 9 years ago, and maybe we'd be making a whole lot more money off. But that really is not what we're into. We're not into it from the business side. From our perspective, the build was the right way to go for what we were doing. I'm happy to follow up with you after.
So we've got time for one final brief question from Haya Lysoff.
Hi, Lysoff with KMH Cardiology and Diagnostics. Good morning, everybody. I think if there's one common denominator that you've all talked about, it's leadership commitment to enabling innovation to occur in your organizations. Just curious in terms of working in the public sector, in terms of how you've looked at and what success you've had in engaging the private sector in enabling and helping you to spread innovation.
One of the industry is one of the many partners and people that we look at in our community of people working together to transform the patient and family experience, and in very real ways engaging in an industry. One of the things we learned early on was some of the understanding some of the mutual interests and commitments to the principles of decision-making that we have embraced. Industry was part of helping to shape those and are part of the decisions down the road with various other kinds of innovations that we've introduced. But at the core of the relationship with industry, the thing that has shifted for us has been in the way in which we make decisions and engage that is still true to the commitment that any decision that we make where there's a material impact on the experience of patients, a patient will be at the table. It is not us in industry, it's actually a different set of players around the table in having the conversations.
Final comment from Kevin.
Hi, for me, the divide is an artificial one. That what we've said is, again, back to the better, cheaper, faster model, and in a world of BPS guidelines, go out and look at who can do this. If they're a private sector vendor, great. If they're a public sector organization, that's fine. But if you're, again, looking for the best opportunity for delivery at the best price point with the best deliverables, your corporate status was of little interest to us.
Let me make one observation as I turn this over back to Anton, and that is every one of these investments was made with the same R&D dollars from the same people, that is Ontario taxpayers. And I think what is beautiful about a session like this is we've started the diffusion process, or it's a part of the diffusion process, so that we don't reinvent the wheel. When Leslee's organization has developed something, you know about it, you can modify it in your organization and across the board. And I look forward to, perhaps I won't be up here anymore, but 4 new faces talking about innovation in the future. I love these faces. But we've got so many other faces in the room and in the province that can be talking about their innovations, and that gives us a greater chance to spread and diffuse the innovation in the system in Ontario and in Canada. So I want to thank, and I'll ask all of you to thank, our 4 guests for their stories.
They're not just any faces, Brian. They are the best faces. I want to acknowledge one other best face that's in the audience. The inaugural Canadian Patient Safety Champion was awarded this year to Miss Carolyn Canfield from British Columbia, and Carolyn is in the audience. Can you take a bow? Thanks for coming down all this way just for breakfast with the Chiefs. The next one is with Michael Scheer, Catherine Zahn, and Staney Brown on March 4th. Details will be coming out for that. I would certainly like to thank our 4 guests today. Every time we make these phone calls or we send out these notes, we get enthusiastic, yes, will do. And we really appreciate it. It's very kind. So remember now, next time, Michael Scheer, Catherine Zahn, and Staney Brown on March 4th. Thank you for coming to Breakfast with the Chiefs.